Darbey Raible. I'm a genetic counselor. Today I'm presenting an article out of the most recent issue of Pediatric Nephrology discussing the potential of RNA-based therapies for kidney disease. In this article, the authors explain some of the basics of RNA treatments. They mention current therapies that are available in kidney disease and other disease states, and they discuss some thinking around potential targets with kidney disease specifically that have shown some promise in preclinical research. So it's been mRNA vaccines that have really caught our attention and dominated headlines recently with the COVID vaccines that were developed in late 2020, early 21. But there's much more to RNA therapies than just that. The FDA has approved a handful of RNA-based drugs. This would include patisiran, which is a drug that was approved for use in patients with hereditary amyloidosis due to TTR gene changes, specifically treating polyneuropathy, but it's also shown some promise in patients with cardiac manifestations of hATTR amyloidosis. We, of course, are aware of lumasiran, which was approved in 2020 for treatment of patients with primary hyperoxaluria. On the mRNA front, there are some additional therapies beyond, again, like I said, just the vaccines that have made it to the clinical trial stage for different conditions. This includes cystic fibrosis. So these are not yet approved, but like I said, have made it to the clinical trial stage. So as I mentioned, this review provides a nice discussion of the different types of RNA-based therapies. They differentiate between the RNAs that are employed in diseases due to loss of function versus gain of function molecular defects. So for loss of function, we're talking about diseases caused by the absence of a functional protein. And in these cases, protein complementation using in vitro mRNA has become an alternative to DNA-based gene replacement therapies. So mRNA can be produced in vitro in a cell-free system. That's a relatively straightforward process, but a challenge is that in vitro mRNA has immunogenic potential and is prone to rapid degradation. So this has to be addressed usually by structural changes to the mRNA molecule, trying to make it more similar to endogenous mRNA and protecting it from degradation. But once that mRNA makes it inside the cell, it is then translated by the ribosome to make the protein of choice. So right now, there are not currently any mRNA replacement therapies that are FDA approved, but some have made it to the clinical trial stage at this point. In the case of gain of function diseases, it is overexpression of a gene or accumulation of a toxic metabolite that leads to disease. So here the goal is to knock down gene activity. This can be achieved through different molecules, including small interfering RNA or siRNA, or antisense oligonucleotides or ASOs. The main difference between these two molecules is that ASOs are single-stranded molecules, while siRNAs begin as a double-stranded precursor. But both of these molecules have a similar mode of action and effect. So like mRNA, they can also be produced in vitro and then introduced into the cellular environment. Once they're inside the cell, they can bind to their corresponding mRNA sequence and then lead to gene knockdown via mRNA cleavage or degradation or translation repression to stop that protein production. These molecules, just like in vitro mRNA, require stabilization through chemical modification, so they can add stabilizing groups to the backbone, for example. This prevents those molecules from being degraded and also enhances cellular uptake. So I mentioned on the prior slide that the in vitro production is relatively easy, but the main challenge is getting these molecules inside of cells. Generally, naked RNA is too large and negatively charged for efficient cellular delivery. That has been done in some cases, particularly if a local injection is used, but generally a delivery or packaging system is required. So there's different types of packaging systems that have been utilized, including lipids, peptides, and polymers. The most frequent are the lipid-based delivery systems, liposomes or lipid nanoparticles. The COVID vaccine, for example, uses a lipid nanoparticle to package mRNA. The FDA drug-approved patisiran that I mentioned for hereditary amyloidosis uses a lipid vehicle to deliver an siRNA to the liver to inhibit TTR protein production. There's also a mouse model for a lipid nanoparticle in vitro mRNA for Fabry disease that can, at least in a mouse model, increase alpha-galactosidase production in the liver. And generally speaking, lipid particles do largely target the liver, which works for hereditary amyloidosis and Fabry disease. But there has been some ability shown to accumulate in the kidney, so they still hold promise for conditions where the problem doesn't necessarily originate in the liver. Polypeptide vehicles are being explored mostly in cancer immunotherapy and infectious disease. There's really not been much application in kidney delivery as of yet. And positively charged polymers can also shield RNAs from degradation and promote cellular uptake. There's a mouse model of an intraperitoneal injection polymer-based siRNA that may improve kidney function and ameliorate sclerosis in glomerulonephritis. So some promise shown there. So thinking specifically about targets related to kidney disease, the authors discuss some challenges and opportunities in targeting certain cell types. They mentioned that the glomerular endothelium is a tough target. There's a low number of cell-specific receptors, but these cells do play a central role in inflammatory disease. So there's been some evidence that delivery of siRNAs to inhibit expression of those inflammatory factors may attenuate inflammation. The mesangial cells, they maintain, of course, the capillaries and aid infiltration. And if a molecule can pass through the endothelium but is ultimately too large to be filtered, it can accumulate there in the mesangial cells. There are mouse models of glomerulonephritis and IgA nephropathy where siRNA has been shown to accumulate there and may potentially reduce sclerosis and glomerular inflammation. The proximal tubular cells are probably the biggest target of research just because there is such a large array of diseases that affect the tubular epithelium. In order to get to the tubule, you do have to be able to pass, of course, through the glomerular filtration barrier. So you either have to have a small molecule or you have to have some degree of glomerular damage for larger particles to make their way through. Teproserin is a drug that's in clinical trial phase currently. It uses a naked siRNA to treat DGF after transplant or acute kidney injury following surgery, for example. The authors then spend some time postulating about future directions where RNA therapies can go to better target kidney cells and kidney disease. So the delivery systems that we talked about earlier, the lipids and peptides and polymers, these really lend stability to the RNA, but they are not targeted vehicles. So they discuss using ligands conjugated to the delivery vehicle to better direct the RNA to the desired cells and also minimize the effects to off-target cells. So they show that there's different ligands. There's 5 main categories. The clinical experience with these ligands and cell targeting is lacking currently, but some clinical research has shown promise. They do go into a full rundown of these ligands and how successful the preclinical research has been so far in targeting different cells. They also discussed the importance of injection strategies. Systemic application is the least burdening in terms of administration, but again, this can pose a problem for the nanoparticles actually getting to the kidneys, whether they're sequestered and degraded by the liver, can't cross the glomerular filtration barrier. So they've also looked at local delivery. Via the renal artery, the renal vein, even direct injection into the parenchymal cells has been studied to circumvent the issues with systemic injection. This has, of course, the disadvantage of being more invasive and difficult for patient and provider. And they finally discussed some physical manipulations that might be used to target delivery to certain organs. This hasn't really been used previously with RNA therapeutics, but they do mention drug delivery models that use ultrasound or electroporation and other physical methods to increase cargo release or cell permeability. I realize this slide is probably a little tough to see, but I think it really sums up the potential impact on clinical care. As I mentioned, there are FDA-approved drugs in this space, so this is not at all a pipe dream. There are many additional therapies in clinical trials or preclinical trial research at this time, and undoubtedly the increase in genetic testing being afforded to the kidney disease community is going to contribute positively to the research that's allowing for the development of these new therapies.